medicine. Do you want a chair? So now we're going to have flashbacks to the COVID thingies. Well, next slide, please. just so you don't get flashbacks or anything like that. So I'm a bit nervous, ladies. I won't tell a lie. I've just made this presentation this week, okay? So I apologise for any spelling mistakes, any things that are in there that I should have taken out, and things that I should have put in that I haven't put in. Okay, so it's gone. What are you doing? What happened? I know, but why has it gone to that already? I'm not ready. I need a new next slide, please, Buzz. Okay, so today I'm going to be telling you a little bit more about what we as medical professionals can offer you from a menopause management point of view. Okay, the British Menopause is that now you can do it. Thank you. I know it's quite small, I apologise, there's a lot of information on this slide, but first of all let's just go through again what is menopause. So menopause is a particular point in time when you have your last period, when you stop producing eggs and you stop producing estrogen. That is your menopause. Okay, so what we're talking about is perimenopause, which, as Catherine talked about last week, is the period of time before you have that last period, and that can last anything from 7 to 10 years, and everybody will experience a different perimenopausal time. Some women will just have no periods, that's it, the end of the periods, never have another one again. Some ladies have heavier periods, lighter periods, long times in between periods, and that's perimenopause. But this is where most of us experience the worst symptoms and find that it's most difficult to deal with because it's not menopause and there is no blood test to tell you that it is menopause. Okay, post-menopause you can still experience symptoms. So post-menopause is after that period that you've had your last menstrual bleed. Okay, so every woman in the world, every non-binary person who's got an ovary in a womb, and every transgender who's got an ovaries in a womb will also suffer from menopause. So that's about 51% of the population. And like I say, we will all experience very, very different symptoms, very different menopauses. And, you know, we have to be able to function as we should be able to. Okay, so like I said there, hormone blood tests aren't recommended in the majority of cases. There's a very small amount of people, if you're not having periods because you're on the Mirena coil or you're on the mini pill, then absolutely there is a blood test that we can do that will show us if you are post-menopause, but there is no blood test or urine test or anything that we can do to tell you whether you are perimenopausal. And I've not long recently this week spoken to a lady who told me she'd done a test that she'd got off the internet. Waste of money, don't do it. No, absolutely no point. So along with the other symptoms that we might, do you want to flick the thingy please? So we all know about the symptoms of menopause. I know that's not very, you can't see it very clearly, but it's on the sheet that the ladies got over there and in the handouts that we gave you. Okie doke. But apart from all of these symptoms that can affect our general day-to-day life, how we function at work, how we function at home, whether we want to punch our husband's lights out, whether we want to have sex with them, we have to consider the other things that will be affected by the lack of estrogen, and that is osteoporosis. Your bone health will start to go down. Your risk of cardiovascular disease and type 2 diabetes will increase as time goes on. Okay, so it's not just about how we feel in ourselves, it's also about what's going to happen to our health in the long term. At 50 these days, we've got another 30 to 40 years to live, and in the majority of our cases, we're going to be working for another 20 odd years as the way things are going. So we have to keep ourselves in optimum health. Next slide, please. Okay, so why do we get symptoms with menopause? Most tissues in the body are estrogen dependent. Okay, now that's everything. Some ladies get dry eyes because the eyes start drying out. Some ladies get dry vaginas. That's a very, very typical symptom, and a lot of ladies don't recognise that symptom because it's just a bit of an itch, or in drastic cases, you know, people can't wear clothes or they can't walk, they can't sit down. But so, you know, the tissues are drying out. The amount of perimenopausal and postmenopausal women who are getting recurrent urine infections, and it's not an infection, they're getting many courses of antibiotics, it's a lack of estrogen in the tissues around the vulva, the vagina, and the urinary tract. Okay, so obviously we have to consider the antimicrobial resistance crisis that we're in as well, and giving these ladies repeated courses of antibiotics isn't helping them at all for that. So the reason that we get all of these symptoms is because we're not getting the receptors, the estrogen that we need. Next slide, please. Thank you. So, treatments for menopausal symptoms. We always start with the, I won't say easy stuff, because these things aren't easy. These are probably the most difficult things for women to do when they hit menopause. And it's the lifestyle changes, because we want to have a glass of wine every night when we're watching the telly. We know we're going to put a bit of weight on. We can't be bothered to exercise because we feel a bit fat, a bit bloated, and we've got no energy, so we don't want to do those things. But these things are really important to try and build into your life alongside HRT, if you can take HRT, which we'll get onto later. So we have to look at the whole picture. We're not just looking at a medical treatment for the symptoms. We're looking at the other things that we have to do alongside that to support what our body needs. Okay, next slide, please. Okay, so non-hormonal treatments. So these are things that you can buy over the counter, all right, and other different types of treatments. So the herbal remedies, we've probably all tried the black cohosh, the sage, red clover, menopause, all the different supplements for women. There isn't any clinical evidence to suggest that any of these are going to help. Try them by all means, and a lot of ladies do try them first, and that's fine, but most women find that they are not helpful. But it's absolutely fine to try them. If they help, fantastic. If they don't help, well, you haven't done any damage, so, you know, see how you get on with that. If you do buy any herbal treatments, look for the herbal what is it called? Traditional herbal registration logo, okay? Because then that kind of guarantees the quality rather than just something that could be anything from anywhere. Phytoestrogens from plant sources. I eat a lot of soy because I'm vegan. Didn't help me, just putting that there. But the evidence shows that women in Japan who do have a higher soy-based diet don't have as many hot flushes as Western women. Okay, maybe I just don't eat enough. I was too late in the game to make that, for that to make a difference. CBT, which we are going to be having a talk from somebody else too, is being shown to be really useful for women with hot flushes, sleeplessness, stress and anxiety related to menopause. And I think that's especially useful for our breast cancer sufferers who maybe can't have HRT, but I know we've got somebody else coming to talk about that at another time who's far more expert than me, so I'll just leave that there. So yes, so the CBT is useful for women who can't have HRT. Next slide, please. Okay, so non-hormonal medications. So now we're on to the medical type of treatments that we can give you for menopause that are not hormonal. You can see that I'm leading up to the HRT because I know everybody wants to know about HRT, but it's very important that we discuss all of these other things that can help. Okay, just in case when we get to the end, we can't give you, you can't have HRT. I want you to know that there are other things that may be helpful. Okay, so clonidine is really useful for hot flushes. So this is not a hormonal treatment. So if you can't take HRT for whatever reason, or you don't want to take HRT, that's absolutely fine. Clonidine can help with hot flushes, and night sweats is your main symptom. Okay, venlafaxine is one of them. I'm not even going to pretend to try to say it because I'm going to make a mess of it and I think I'd look more foolish, but it's like an antidepressant medication. Okay, it has been shown to reduce the symptoms of hot flushes for women. Okay, so again, that's something else that we can offer in primary care if you don't want to take HRT, or women who've tried HRT and it really hasn't done what they wanted to do. You know, these are other things that we're going to try to see if we can make a difference for you. And I know a lot of women say, I've gone to the doctors with my menopause symptoms and they've tried to give us antidepressants. It isn't first line for menopause symptoms. However, again, for those ladies who can't or don't want to take HRT, we can try them with a low-dose SSRI antidepressant like fluoxetine or citalopram. And there's nothing wrong with taking these alongside HRT if you already suffer, or if anxiety, depression, low mood are your main symptoms. You know, so HRT might work for some things, but then you might need to top up with an antidepressant, and there's absolutely nothing wrong with that. I'm on both. I'm on HRT and I'm on antidepressants. Okay, life's tough these days. It's really tough for middle-aged women who are looking after kids, who are doing full-time jobs, who are suffering from menopause symptoms, who are looking after elderly parents in a lot of time. Don't beat yourself up if you feel like you need mental health help as well as hormonal help. Okay, there's millions of us out there who are suffering exactly the same thing, and don't be scared to say to your medical practitioner, I feel like I need this. Okay, so no, not yet. We haven't got I know what I was going to say, but then I didn't realise. I hope Stephen's good at editing. So, non-hormonal vaginal preparations. Those of you who were here last week, Catherine kindly provided some samples of Yes Vaginal Moisturiser. Okay, this is really good if you're dry and when you're having sex and you just need a little bit of extra lubricant, or if you think, oh well, I don't really need something all of the time, but sometimes I get a bit sore and itchy down below, so just something to help with that. Absolutely fantastic. We don't do them on prescription anymore, unfortunately, so you would have to buy that. And Catherine had some leaflets last week. She's got some more as well, of where you can get that from. Okay, next slide, please. So, hormone replacement therapy. It's quite a big subject, okay? Now, when I was making this presentation, I thought I want to make sure I give you all of the information that you need, but I don't want you to be confused by it. Okay, so please make notes if there's anything you want me to clarify at the end by the time we get to the end, okay? You don't have to learn this. There is no test. All right.
You also go on the files part in the Facebook page. On the files part, we will be putting that on there by tonight, tomorrow. Yeah, and my presentation is on this. Every weekend's presentation will go under that files part as well.
So this is just giving you an understanding of what's available, what works for what type of women, and you know where things should be. So it may well be that you're on some HRT and you think, oh, well that doesn't sound like what I'm on, or oh, I'm on that, but I think I'd prefer that. Then it just gives you that information, that knowledge. Or if you've never been on HRT and you're thinking about it, it really gives you a lot of information about, right, oh, well, that sounds like it might work better for me than that. Okay, like I say, please don't worry too much about listening, about digesting everything that I'm saying. The presentation will be there. There will be loads of questions. I know there will be loads of questions, but bear with us and we'll get through. Okay, next slide, please. So, the pros of HRT are it is gold standard treatment for menopausal symptoms. Okay, the British Menopause Society and other female health bodies are calling it symptoms of menopause, as is nice, rather than female hormone deficiency. Okay, which is what it is. However, the bodies are saying menopause symptoms. Okay, so it's important if you go into your GP or your medical practitioner that you're telling them that you've got menopausal symptoms that you want treatment for. Okay, because that's what it's licensed for, and that's what people are confident and happy to give it for. Okay, so I'm going to be giving you tips like that on how to approach your practitioners or your doctors, you know, so that you can present it in the best way possible to get the best result from the consultation. It does reduce your risk of osteoporosis. Okay, so osteoporosis is thinning of bones, which happens as we get older. And normally we only find out somebody's got osteoporosis when they fall down, break the wrist, break the hip, and then we'll find out they've got a fragility fracture, and then we've kind of missed the boat on that. Okay, so HRT does reduce the risk of osteoporosis. It's likely to provide cardiovascular protection. So talking again about heart attacks, strokes, high blood pressure, which we're more at risk of, this does help to bring it down, and that is by about 40%. It does say if taken before or within 10 years of menopause. So that's what the evidence, that's what the literature shows us at the minute. Most of us aren't going to know when our menopause is, because I can't remember the last time I had a period because of contraception or me Mirena coil. So we just have to kind of guess and hope that we hit lucky in that 10. It's a big gap, isn't it, 10 years? So, you know, that's why it's important when you identify the symptoms that you do act on it, so that will get you in the right group there. Reduces the risk of type 2 diabetes by about 30%, and important of all, improves the quality of life. Okay, we don't want to be dried up, wizened old, hairy-chinned hags who can't be bothered to do anything, do we? We want to be vibrant, we want to be out there doing the things we want to do, you know, and this will help with that. Okay, the cons of HRT are really quite minimal. Increased risk of blood clots with oral estrogen, but that's only with oral estrogen. If we give you a patch, I'll show you a patch. Oh yeah. Give you a patch, this does not increase your risk of blood clots, okay? But we'll get onto that a bit later. It won't suit everybody, okay? So it may well be that you try it, we try this, we try that, we try the other, and you think, look, it's just not suiting us, I don't want it anymore. Absolutely fine, you know, but my advice on that is that you keep going back and say, I don't like this because of, I don't like this because of this, this has given me this symptom, I don't like that. So then we can tailor it more to you, okay? And it might not relieve all of your symptoms of menopause. We'll do our best, you know, but we have to, at some point we may have to say, you know, this is as good as it's going to get. We need to be looking at other things, we need to be accepting how things are, and that's where CBT, mindfulness, and all of the other things around us come in, okay? So, these are some common questions about HRT. I don't know if you can see that because the writing's quite small. No, it's all right, it'll be, the presentation will be on later. So these are just questions that I thought people might, you know, that people have voiced last week and that are here at work and on social media and things. So I just thought I would address them now. And, you know, obviously you can ask other questions at the end. So I've had breast cancer, can I have HRT? Mostly no, sometimes yes. Okay, it depends what kind of breast cancer you've had. And that should be a discussion between your medical practitioner, whether it's your GP, nurse practitioner, and your breast oncologist. Or you can go straight to your breast oncologist and say, can I have HRT? Okay, and they might say, yes, you can have this, or no, you can't. So it's very much a conversation to have between two medical professionals or you and your medical professional. Okay, because some ladies can, it depends what type of breast cancer it is, and they know what the safe types are, we don't. Okay, so that's that one. I have a family history of breast, endometrial, ovarian cancer. Can I have HRT? Absolutely, not a contraindication. Okay, even if you've got a family history of BRCA, then again, you'll probably have had genetic testing done, family history taken done. So again, it's not an absolute contraindication, but the majority of women who've got a family history of a female cancer can still have HRT. I have endometriosis. I'm worried about using estrogen. Will it make my endometriosis flare up? So endometriosis is a condition where bits of the womb lining grow outside of the womb. Okay, and also you get an overgrowth in the womb. So when your estrogen levels go up, when you're releasing an egg, everything flares up. You get excruciating pain, mainly around the pelvis and the abdomen. So if we're giving you extra estrogen, is that going to make that happen every month, even though you are perimenopausal? It can. However, then we use the progestogens to balance that out, and we'll come into the progestogens later. So it's not, it might, there's nothing that we can ever say, no, it will not. We can always say it might or it might not. And the best thing to do is suck it and see, try something low dose, and then gradually increase it and see what your levels are. If we get some resolution of symptoms, great. If we don't and it just flares your endometriosis up, then we stop and then we reconsider what we do from there. So it's, again, it's very much a tailored situation for that individual lady. I have had a blood clot, or a close family member has. Will this affect me being able to use HRT? As I said before, transdermal methods, so that's the patch, the gel, the spray, do not increase your risk of blood clots. Okay, so if you've had a blood clot, you've got a family history of blood clots, you can still use it. If you've got an active blood clot, so if you've just been diagnosed with a DVT, we'll probably say, not at the minute, let's wait until things have settled down. Okay, so I think that's it. And the next one, please. So I've had a hysterectomy and my ovaries removed, so I'm in surgical menopause. Any specific advice? So it shows that women who have surgical menopause may have more severe symptoms, not service symptoms, and often have a higher incidence of low libido. So we normally need to start a higher level of estrogen, okay, and we would introduce testosterone quite early on in the process. So we'll probably give you estrogen, get your estrogen titrated up, and then add your testosterone in the 3 months. Okay, these women are normally younger, and younger women often need a higher dose of estrogen in the first place. How long will it take to feel the benefit? Now that's the question, isn't it? How long will it take to feel the benefit? 1 day, 2 days, 3 months, 6 months? Everybody's different. Some ladies, they stick a patch on and the next morning they wake up and go, oh my God, I've had the best night's sleep ever and I feel great. Some ladies I'm still seeing every 3 months because it's not quite right. We need to add this, we need to take that away, we need to try this instead, we need to do this. So it's very individual, and my main piece of advice on that is you have to keep saying, this isn't working. I'd prefer if we could do this to try and get a better result from this. Okay, so next please. So these are the direct contraindications. So HRT is suitable for most women except women who've had an estrogen-dependent breast or ovarian cancer themselves, not a family history themselves. Undiagnosed vaginal bleeding. So that's a difficult one because in perimenopause, a lot of ladies who are still having periods will have funny periods. They'll be horrendous, they'll be heavy, they'll be long, they'll be clotty. There might be a bit of spotting this month and then 3 months down the line you're flooded. So undiagnosed bleeding is again something that you need to have discussed with your medical practitioner before we move on ahead with HRT. And sometimes HRT is the answer to that, but we have to make sure that we're not missing anything else like an endometrial cancer or, you know, fibroids or something like that before we move on with that. Pregnancy. Now I know that's a bit weird, but if you're 47, you haven't had a period for 6 months, but you are sexually active, you could be pregnant. You probably don't want to be, but you still could be pregnant. So, you know, don't be alarmed if you are in that age group and your GP says, can you do a pregnancy test, please? Because we have to rule that out, because we don't want to give you HRT if you're pregnant. You might want something else. Okay? Active liver disease. Now, we're talking about active liver disease really only applies to oral HRTs because that goes, when you swallow it, it goes into the, just being very basic here, swallow it, goes into the stomach, gets processed through the liver. So if you've got active liver disease, that's not going to work, or it's going to work too well. So while you've got active liver disease, we just don't give HRT. Obviously, you've probably got bigger things on your mind at that time. If you've got active liver disease than HRT. But again, it's about a conversation with your GP or nurse practitioner and them having a conversation with your liver person. Active blood clots, we've just talked about that. So NICE guidance recommends a 3 monthly review. So you get your HRT, and then you use it, and in 3 months' time you go back to your doctor or your nurse practitioner and say, hello, can I have some more HRT because it's working brilliant, I feel like my old self. Or, hello, my HRT isn't really working for me, please can I have something different, or can I have more? Or, I'm not quite sure, what will I do? So 3 months should be the cut-off at latest. And I always tell my ladies, if you're not feeling the benefit within a month, or you feel like you need to discuss it further, come back, because we can titrate, we can increase the estrogen quite quickly. There's no kind of time frame. You don't have to wait for the 3 months. If you're still feeling rubbish at 1 month, come back and we'll see what we need to do. And I give my ladies who are on things like the gel and the spray some parameters. So if in 1 month you're not feeling better on one spray or one pump, increase it to 2 pumps for months 2 and 3, because we're all grown-ups, we're middle-aged women, we know what we need. We don't need somebody to say, yes, you can only take 1 spray of that until I tell you you can take more. You know, you've got a bit of common sense about you, so give you the choice. You know how you feel, and it might be difficult to get in touch with your doctor. We all know that, to get in touch with your doctor or your nurse practitioner to get that advice or to get that. So giving you a bit of independence on how you're going to manage that, I think, is important. So you could end up needing 3 items on prescription. So if you're getting an estrogen and even if you get a patch which is estrogen and progestogen together, you still pay 2 prescription charges for that. So we might want to take that up with Paul Howell next week. He's going to wish he never came. We'll have to take that bit out of the video just in case he gets a heads up. So if you've got estrogen and progestogen in the same patch, you will pay 2 prescription charges. Okay. And if you need a vaginal preparation, a vaginal estrogen, then that's another prescription charge. Now that's going to be about 30 quid.
I have wrote a bonus about that. Just to let you know.
So, savage Javin. So yes, so ask for prepayments. You get it on there's it's on the web, isn't it?
If you just go if you just Google NHS prepayment certificate, it'll take you to an NHS page. You don't need to have your NHS number, but if you do, that's great. And you can pay, it's either £10 and 8 pence a month for 12 months. You must sign up for the 12 months. Or you can pay, I think it's £30 and something pence for a 3-month prepayment. And that's brilliant, because then you can go, and while you're changing and swapping and getting your prescription right, if you're getting a different prescription every month, it's going to cost you a lot of money. So at least that. You get as many as you want, not just to do with HRT, anything that's on your prescription. So that's one of the tips I would absolutely say. That's one of the things my GP recommended for me to do that.
And the government has said from April next year, 2023, that women will only have to pay 1 prescription charge for their HRT meds for the whole year. That's from next April. We'll hold our breath. Well, we won't hold our breath and see what happens to that, because that was supposed to happen this year, but it hasn't. They put it back to next year. So, you know, we have got lots of people in Parliament shouting about these things. So, you know, they have got our back. So if you can get on and support some of these MPs who are doing the work for us in the Houses of Parliament, that would be great.
If you want a letter, if you let me know, or I can try and get that letter uploaded to the files part of the Facebook, along with the prescription charge letter and the testosterone letter. I'll try and do that. When I say I really mean my husband. The royal we there. So when I say I, it's not me.
You're going to have to watch if you're going to come here, you know, mate. You're going to end up with a list of jobs by the end of the night. Can we have the next slide, please? Okay, so now I want to tell you about progestogen first, because I think it's really, really important for women to understand what progestogen, why you need progestogen with your HRT. It's a safety mechanism, okay? If you've got a womb, or if you've got a part of a womb, so if you've had what we call a subtotal hysterectomy, where they take your womb body away, where's my little womb? They take your womb body away but leave your cervix, then you need progestogen. Okay, progestogen provides protection for the womb lining. Okay, now as you menstruate, when we were having periods, your hormones would go up and down. So your estrogen goes up to ripen an egg, and then your progestogen comes up to build the womb lining up, and then it falls off and you have your period. That's very basic, I understand that, but just so you know, because most of us are past that in any way, so don't really bother about that anymore. So if we give you estrogen, your womb lining is at risk of just building up and becoming what we call hyperplasic. So that means overgrown and abnormal. And then that can lead to uterine endometrial cancer. We do not want any lady to have endometrial cancer because of HRT, because they're trying to feel better, and they're trying to be better in themselves, okay? And that's why we always give progestogen if you've got a womb, a part of a womb, or if you've had endometriosis. Okay, now The depot injection, mini pill, implant, and the smaller coils like Hyalina and Jades, which do have progestogen in, do not provide enough endometrial protection. So if you're of the age where you still need contraception, which is until either a year after your last period if you're over 50, 2 years after your last period if you're under 50, or when you reach 55 if you don't know when your last period was. And these are the methods of contraception that you're using. Brilliant for contraception, no good for endometrial protection. So if you're on them, then you need to be still getting that progestogen to go alongside it. So it can be delivered in various forms and routes. Oh, you can't see me pictures very good. Oh, never mind. Yeah, look at this. So there's a few different types of progestogen that we can use. Okay, next slide, please. So the coil. This would be what I would consider gold standard for your endometrial protection, because especially if you're perimenopausal, it'll stop your periods, it works as contraception, and it's really good for your endometrial protection. And it means then you can have estrogen-only HRT, which means you don't pay for your progestogen, but you can change your estrogen easier if you've got a separate progestogen and estrogen. Does that make sense? Please tell us if it doesn't, because sometimes I don't, if I'm not just explaining myself. So the Mirena coil goes inside of your womb. Okay, so this is your womb. Well, not yours personally. This is the collective womb. It's Catherine's royal womb. So this is your cervix. This is where we do your smear test from. Okay, and you must still make sure that you are getting your smear tests, okay, until you're 64. This is your cervix. This is your womb lining, your fallopian tubes and your ovaries. Okay. Now this is not a Mirena coil. This is a pretending Mirena coil. Okay, they are white. The real live Mirena coils. Did I put one on there? Yeah. So it's literally white. It's a white T shape, but that's what it looks like. And it goes up through your cervix and sits in your womb like that. Okay. The threads stick outside, so that you know that it's there, and so we can take it out when it comes time to take it out. For endometrial protection, for your HRT can stay in for 5 years. Okay? And then you can either have it changed, or it depends where you are in your life, whether we want to replace it or whether we want to try put something different. So this is it's not a real live one, because they cost about 100 quid. It's not bad really for 5 years contraception though, is it? But it sounds like a lot of money, isn't it? So basically what we'll do when we put it in is it goes into the womb, we'll push that through the cervix into the womb, open it up, and then we'll leave that inside. Okay? Everyone's like that. No. Yes, you don't go on with this bit in. I have nearly left a speculum in a couple of times, but you know, we always remember when the lady goes to put her knickers on. Oh, I can't get my knickers on. It looks really horrible. It really does, but it's not that bad. I've had a couple of Mirena coils, I've had a couple of copper coils, and what you need is to make sure you've got somebody beside you who's a good verbal anaesthetic, somebody who's going to talk to you, keep your mind off what's going on, bit nippy, bit period crampy, which is a bit of a shock if you've never had a period for a while, but really, really brilliant for HRT. Okay, but it's not your only option. So I know I'm going on about it, but it's not your only option, but I do like them. Okay, now your GP surgery might not do Mirena coils in the surgery. If that's the case and you need to go to a contraception and sexual health clinic to get it fitted, tell them it's for contraception, because they're not funded to put them in for HRT or heavy menstrual bleeding. Okay, so if you go in and say, I want a coil for my HRT, they'll go, oh no, we don't do it for that. So say, oh yeah, I'm sexually active, I need it for contraception. Edit that bit out as well, else I might get wrong. Watch me get fired tomorrow. Kerry, can we talk to you for a minute? No. Right, okay. So side effects, it can be painful and uncomfortable to have put in. Sometimes causes pelvic pain afterwards. If that's the case and we're not settling it down, we'll just whip it out. And if the pain goes away, it was the coil. If it doesn't, well then we'll be sending you for investigations anyway to find out why that happened. Some women just don't fancy it. You know, sometimes you mention it to somebody and they go, oh God, no, I don't want a coil. Fair enough, fine. I'm telling you all your options. If you don't fancy it, absolutely fine. And it might be difficult to fit in some women.
Never guessed it. Did you know? I didn't try. The doctor did yesterday, and no.
Sometimes it can be difficult, but it's an old wives' tale. Well, it's not really an old wives' tale. It's old-fashioned to say that women who haven't had children or haven't had vaginal deliveries can't have coils. Yes, they can. It's not a contraindication. Sometimes the hole, the os going into the womb is a little bit tighter, a little bit smaller, but you know, you might get somebody who's had 3 kids by cesarean section. You might have somebody who's had a child 30 years ago. You're trying to put one in. I mean, their os probably isn't going to be any bigger than mine, is it? I haven't had kids, by the way, just so you know. Just so you know so that's the Mirena coil.
Can I just ask?
Certainly.
What? Do you not lose the string?
No, you can, but you rarely do.
Like a tampon, do you? Yeah?
No, because it's sitting outside of the...
You might not be able to find it.
Yeah.
I've got a coil. You might not be able to find it.
'Cause-
Where your cervix sits.
Yeah, and sometimes it's like curls up around the cervix, so oftentimes you just can't see or feel them. I've never felt my own coil strings. They're really oversharing, aren't they?
We like to have so we have a smear test.
Yeah.
Usually it checks.
Yeah, they'll see if it's still there.
And it's no different having a smear test, ladies. I have to say it was a total game changer for me having mine fitted, and it is. You just feel like you've got through period cramps, like after yeah, I promise it's no worse.
No, I tried to get it and I was screaming in pain at night, like massive.
Well, my first time took me 45 minutes because I couldn't find different. They were trying different different speculums.
Oh yeah. Mm-hmm.
The second time it flew.
Yeah, and
It was fine.
everybody's it's the same as everything else to do with women's health. So everybody's very, very different. Some women have a dreamy experience. Well, dreamy maybe it's not so much, but have a reasonable experience. Some women, like you, darling, just have a horrible experience, and it's not for everybody. But you know, it's worth a try, especially if you're suffering from heavy painful periods.
Still do it, but there are certain days
For
to do the Mirena coil.
is that for contraception or is it for HRT as well? Cool, that's fine. It's the sexual health clinics that can't do it. That can only do it for
I
contraception.
won't say the name in case he forgets to edit, but the doctor was fantastic yesterday. Yeah,
So would you try it again then, or not?
If you would let me try it again, because if you...
I've had it done twice.
Yeah, then I would be, when I say I would be happy to, I found it really uncomfortable, but I think that was because of my cervix and everything. But yeah, I would try again because it's
like
that
a smear test.
progesterone.
Yeah.
Your legs are kimbo, they get set
Yeah.
exactly like they do. You don't feel it really kind of going in, it just the cervix is in a particular position
Yeah.
to kind of get it.
It was a little bit uncomfortable, like you say, like a smear test.
If you do have problems, you know, you can be referred to gynae. They can do it under general anaesthetic if it's something that you really desperately want, or they can do it with local anaesthetic. They can anaesthetise the cervix, so that kind of, you can't feel it going in. So there are options. What's that? Yeah, absolutely. I think that's a good idea. So that's the Mirena coil. Okay, is everybody okay with that? Any more questions? Any more questions while we're on that? No, brilliant. So the next line would be the micronized progestogen, which is utrogestin. Now I don't have any packets of that to show you because I've got some bits and pieces here because I've never had it before. But this is the one, who's watched Davina's documentaries? Yeah, no, you're talking about the body identical hormones and this, that and the other. And on the last one they were saying there's certain places in the country where you can't get utrogestin because it's not on the formulary. We're fine with that here. We can have this all day long, every day. Okay, so it's molecularly identical to your body's own progestogen, and we can use it continuously or sequentially. Right, I'll talk about that bit now because this is where it can get quite complicated. If you haven't had a period for more than a year, we usually put you straight into continuous combined HRT. okay, because we know you're unlikely to have another period. So that's the continuous, and for that you would take your progesterone every day with your estrogen. Cyclical or sequential is primarily used for women who are still having periods. Now, if you're having regular periods, if you're having irregular periods, you will normally be started on cyclical or sequential, which is the same thing. Two different words, same meaning. Which means for 2 weeks of the month, you will get progesterone. For the other 2 weeks, you won't get progesterone, but you'll have estrogen all the time. When you stop taking your progesterone, you'll have a bleed. So the rationale behind giving people cyclical HRT who are still having periods is that you will have a regular bleed. You will know when you're going to bleed. However, there is no contraindication to a woman who is still having periods to having continuous combined hormone replacement therapy. Okay? But you might get spot and you might get bleeding here, there and everywhere. So if you want to know when your period's going to come, when you're going to have a bleed, cyclical is the one for you if you're still having periods. If you don't care about a bit spotting here, there and everywhere, continuous. Or if you haven't had a period for more than a year. Okay? You don't need to know that really. It's just so that you've got an idea of why. Because a lot of women will start HRT and say, I don't like having a bleed every month. I'm going to stop it. I did that when I first went on HRT years ago. They started me on Femiston, which is a combined sequential HRT. And I couldn't be bothered with the bleeds. It just did me head in. I mean, you get into menopause, it means stopping of the periods, doesn't it? Stop my periods. We don't want that. That's why I went for the Mirena. So just so you know, if you are in a sequential regime, you will have a bleed every month. Okay? Now, after 5 years of being on sequential, they'll change you on to continuous if you've been on it for 5 years. So with the Utrogestin for your sequential, there are a few different ways you can take it. You can take it for 3 months and then have a break. You can take it every 2 weeks every month and then have a break for 2 weeks. So there's lots of different ways that you can take it. All right? If you wanted to take it cyclical. If you're taking it continuous, you just take one at night before bed. Before bed, because it does have a mildly sedative effect, so then it is much better for you ladies who are having problems sleeping, which is probably most of us. Because I think there's probably very few and far menopause women who are having a proper full night's sleep. So, any questions about Utrogestin? Oh, and I've got another point to make. Sorry, did you want to?
I was just going to say, so that's the same if you've got the coil, that does exactly the same job.
Yes.
Yes.
The coil, the Utrogestin, and the Provera all do the same job. They're just 3 different hormones, 3 different progestogens. Okay. What I was going to say as well is with the micronized progestogen, some women do feel nauseous when they take it. Okay. If you start to feel sickly when you're taking it, all is not lost. You can just stick it in your vagina. True story. Everybody's face that.
I'd have to lather up with cream.
So the oral capsules can be taken vaginally as well. Okay? So if you are feeling sickly on it, but otherwise you're feeling great on it, you can obviously chat to your doctor or your nurse practitioner about it, but you can ask, can I take it vaginally instead? It's exactly the same capsule as you're taking orally. There is a vaginal capsule that you can get.
You can't take orally.
Yeah, you can't take orally, but it's very expensive, and the oral capsule does the same job, so why would you use something different? So that's Utrogestin. Now, Provera, people who've had the period stop for going on the holidays back in the day when we used to have periods, sometimes you might have had Provera to do that. Or if you've had heavy bleeding and they've given you something to stop your bleeding for the short time, they'll give you Provera.
Is that like northisterone?
No, northisterone is a different progestogen, but yes, so it is a progestogen like that, but this is much safer than northisterone. Because northisterone is a horrible, horrible hormone. I don't know why anybody would want to take northisterone.
You don't take any pills or anything. It would work. there's only one.
Right. So the Provera, we can use this as your progestogen as well, and we find this is really useful for people who do get bleeding, who do suffer from heavier bleeding, because it's more effective at stopping bleeding. Okay, but if you were taking it to stop your periods for your holidays or for heavy menstrual bleeding, you would take 10 milligrams 3 times a day. For this, you would just take 1 5 milligram tablet once a day, or the same kind of regime as the Eutrogestin. Okay, so the point is there's options. One size doesn't fit all. What might work for one person might not work for another person. So there is options to discuss with either your own GP, or if they haven't got the specialist knowledge, to refer you on to a special menopause clinic. Okay, next slide, please. So, other hormonal HRTs, I'm getting onto don't worry, I'm getting onto the magic bit about the estrogen. We will get there. I'm keeping you in suspense. So other hormonal HRT, it's something called Tibolone. Now, I don't use this very often because I don't see the point in it. But it is there. It is something that we can use if other things fail or we don't get where we want to with that. So it's a synthetic steroid, so it's got estrogenic, progestogenic and androgenic properties. So androgenic is like testosterone. Okay, so we use this primarily for hot flushes and for loss of libido if you don't fancy HRT. Okay, so that is there as well. It's just 1 tablet a day. So there's just another option that you can use. Next slide, please. So now this is the magic. Okay, this is what we've all been waiting for. This is what we haven't got anymore. This is what our bodies just says, I'm not doing that anymore. So now we're going to give it all back so that we can re-estrogenize all of those tissues and try and make life a little bit easier and better for us. So that's all of the things that it will help with. Okay, I'm not going to read them all through because there's a long list there. Can you all see it?
Yeah.
Yeah.
Is dementia on there as well? Some of the evidence out there, isn't there?
Currently isn't enough evidence to support the use of HRT to reduce the risk of dementia. And I know Davina did talk about that on the last programme, but there isn't enough evidence to say that that will help. There is lots of research going on, but that we can't recommend it for that because we do not know that that is indeed the case. There's research going on to say to people who have more severe menopausal symptoms, more likely to develop dementia. As you can imagine, it's a really difficult area to research because people with dementia don't know when it started, they don't know what they did in the past a lot of the time, so it's a really difficult area for research, but we cannot recommend it we can't say at the minute that it can reduce your risk of dementia. Okay, the cardiovascular disease, osteoporosis and the diabetes is proven, but the evidence just isn't there for dementia. Okay, hopefully it will be at some point, but it just isn't there. Okay, so I did put that in there because I know it's something that had been talked about, and I just wanted it to make sure everybody was aware of that. So if you don't have a womb, you will get unopposed estrogen, so no progestogen for you ladies. If you haven't got a womb, yay! One prescription charge. Next slide, please. So again, there's some pretty dodgy pictures there, but I've got some bits and pieces that we can pass around as well for people to have a look at. Look at this, I was very proud of it. I didn't draw this myself, obviously, I just got it off the internet. But estrogens, these estrogens that we use in HRT are identical molecularly to our own estrogen that we produce in our bodies. It's different to the estrogen we give in the combined contraceptive pill. Okay, that's why it's safer and we can use it for women who couldn't have the combined contraceptive pill in their younger days. All right, next slide, please. So, talking about oral medications, now I don't have any tablets because I've never used them. A slightly higher risk of developing blood clots with that. But if you used to be able to take the combined pill when you were in reproductive stages, then you can have oral HRT. There's no problem with that. Okay. Generally these days we tend to go for the transdermal methods because they're just nicer and just nicer. I don't know. Maybe oral HRT is old-fashioned, basically, is what I'm saying. The same way as contraception, we've got so many different options for contraception now. Using the pill, it's kind of old-fashioned. So from that perspective, so these are the different brands and names of oral estrogens. Okay. Now they normally come in anything between 0.5 milligrams, 1 milligram, 2 milligrams a day. Okay, now Premarin, the pregnant mare's urine, is a horse hormone. All right, we rarely use that these days because that does have a higher risk profile than the others. Okay, and I'm not just saying that because I'm a vegan, it's legit the truth. So this can be used as estrogen only or with an additional progestogen. So any of those progestogens that we've talked about before, you can add an oral estrogen in with that. Okay, next slide please. Transdermal, through the skin. So these are the ones that we generally use as first line these days because of the safer risk profile, and they're often easier to use than taking tablets. So the patch. So this is the patch. Now they come in various shapes, sizes and doses, anything from 25 micrograms, which is the smallest patch, all the way up to 100 micrograms, which is the highest dose patch. Now this one is the LS Solo MX, so it's just estrogen. You just peel it off, and I like to stick it on the bum there because I think that's a really good place to stick it. If you put it on the side of your leg when you're pulling your knickers and they're up and down to go at the loo, it rolls off. You put that picture on of Penny Lancaster. Did you see it? She had like a short skirt on like this and a big estrogen patch on the side of her leg. Way.
She was trying to prove a point though.
I don't know. Maybe. So this is the LS Solo MX. Okay, so that's quite a big patch, but the Everell is about that size. So is the Fem 7. The Estradot is about that size.
Question then. So the Everell, is that just estrogen?
Some of them are. I'll come to that in a minute. Because you're thinking about you're on yeah. So yeah, that's I'll come to that in a minute. Bear with us. So the Estradot is quite small, which is great. However, when I'm trying to cut mine up into 3, my 75s into 3 to make us up to 100 because I'm waiting for a prescription, it's really fiddly. Okay, so if you know what dose you're on and you're sticking on that dose, the Estradot is great. Everell is great as well. Fem 7, not my fave because they don't stick very well, and I get women phoning back after a month saying I've run out of patches because I'm having to change them every day. Well, that's not working. So the patch, the estrogen is in the glue on the patch. Okay, so the patch must be stuck to your skin. If it's not stuck to your skin, you're not getting any estrogen from it. Okay, so, people in the past have said, oh, stick a Tegaderm over it. Well, fine, if you've just put it on and you're sticking the Tegaderm on to stop it from lifting in the first place, but if it's already lifted, you need to replace it because you're not getting the estrogen. So the glue has got the estrogen in. I don't know which side that's going. I'm not going to.
It's the same as if your patch starts crinkling or lifting up as well. Sometimes the patches can get quite crinkly if they do that, and just that's a good indication.
Yeah, just.
Obviously, you're not getting the estrogen through.
Or if you punch your husband in the face, that's a good indication that you're not getting the estrogen. You're not getting the estrogen through.
Say if you put your patch on and it doesn't work out, it goes crinkly and you put another one on. Do you have to ring up your nurse and explain that you've used more patches?
No, it's just if you're requesting them like every month, and I'm giving you a 3-month supply, and your phone is every month saying I've run out. Well, I'm not very good at maths. I ain't no Carol Vorderman, but if I'm giving you 24 patches, that shouldn't be lasting you a week. It should be lasting you a bit longer than that. They usually come with a little chart in because you change it most of them twice a week. I know you're really good with yours. You're a Wednesday and Saturday girl. I'm like, what was I doing? When did I? Oh yeah, it must be time for a change. Change it. Don't be too hard on yourself. If you cannot remember, if you forget when you've done it, when you need to change it again, as long as you're changing it twice a week, make life easy on yourself. If this is going to be useful for you, use it. If having your set days is useful for you, do it. Everybody's different. If you want like to fly by the skin of your teeth like me, yeah, do it. we're all different. So that's the patches. They are really useful, and yes, they do come in continuous ones, but I'm sure I've got some slides on that later, but well done for noticing that. So that's the patches. Gel. Now, I don't know why we're even bothering talking about gel, because I don't know when we're ever going to see gel again in this country. But some ladies love gel, some ladies hate gel. Again, everybody's different. It's a really good method of delivery. So it comes in a pump and you rub it on your skin, anywhere except for your boobs. Okay, so you might want to put it on there. The Estrogel is quite a large volume from what I've been told. So if you're up to 4 pumps of Estrogel, yeah, go on. Trying to find a patch of skin to put it on. Okay, Sandrina comes in a sachet, and that's a higher dose than the Estrogel. Okay, so it's a smaller volume. Ladies often find that better. We can't get any of that in anyway, so it's all academic. But in the future, we might get gels back, which will be great, because a lot of ladies did like the gel, and it makes it really easy to increase doses just quite quickly, because we don't have to change your prescription. You've got it there, and you just use more or less, whatever. Now the spray is great, but surprise, surprise, we can't get these either at the minute. So I really like the Lenzetto spray. This is really good for older ladies who probably need a lower dose. It's not very good for younger ladies who need higher doses, because it is a low dose. So one spray of this is equivalent to a 25 microgram patch. So to get your 50 microgram, which is a starter dose, you're going to need 2 or 3 sprays a day. Okay, but it is really nice. It's a nice thing to use. Loads of plastic, which I don't really like, but it's dead easy. You just give it a shake, put it on. I'm going to give myself an extra boost, and you just, oh, it's empty. It's empty. So you just spray it on your arm there, and it dries really quickly, and it really is a nice product to use. I'm not selling it, but I've got no affiliate. I should have done a declarations of interest. I've got no declarations of interest except for to this group. Now, there's a little chart on the side, so when you're using it, you mark off how many sprays you've used, and then it tells you when you need a new one. And there's always a few little extra ones, so you can keep it in the back of the cupboard, so when you need when you've run out, you can give yourself an extra squirt. So that's your different estrogen onlys. So if you've got a Mirena coil, or you're taking Nutrigestin, or you're taking Prevera, you can have any of those if you can get them.
Can I ask in terms of the gel, do you have any recommendations in terms of time of day when you should be doing that?
No.
And can you restrict it to say if you were like 2 or 3?
You can if you feel like that works better for you. Okie doke. So some women feel like if they use it all at once, they get a really big boost, but then it wears off, because don't forget that medications go up and then they start wearing off. So you might find that splitting it will work better, putting some on in the morning, putting some on at night. It's important that when these are wet on the skin, you're not rubbing them all over your husband unless you want him to have boobs. Okay, because we all know how expensive bras are, and we don't want the men to have to start with the bras, do we? So make sure it's dry before you touch the dog, the kids, the hubby, anybody else really.
And are there any side effects to estrogen coming in gels?
No, except for if you're a man or a dog or a child, you might get boobs. No, there isn't. There's far more benefits than drawbacks, and especially the transdermal methods. It's really safe, so there's a very low risk profile for the majority of women. So now we're getting on to your combination preparations. Okay, so again, they contain progestogen and the estrogen, and again, either continuous or sequential. So this just makes it a bit easier. If you're starting out on HRT and you think, oh, I just want to get started on something, might try a continuous combination treatment, okay, or a sequential treatment, because it's easy to give you a box of patches and say, right, you put that one, change that twice a week, or change that once twice a week for those ones, and then those ones twice a week for 2 weeks. It's really easy to manage that. Because it's kind of like a middling dose at only about 50 micrograms for the patches and about 1 milligram for the orals, it doesn't really give you much scope to increase. Okay, so it's a good place to start, but a lot of ladies won't stay on that long term because they need more. If you are on a continuous combined patch and you feel like you need a higher dose of estrogen, it's important that you increase the progesterone as well. So what some people might do is they might say, right, some practitioners might say, you're on the continuous combined patch, so that's your 50 micrograms. With your progesterone, we'll give you another 25 microgram patch to put on top of that. You won't have enough endometrial protection from the combined continuous patch. So the best thing to do is to cut them in half and use 1.5 patches of the continuous ones. Okay?
That's exactly what's happened to me. They've given us I'm on Everall currently and the ovaries taken out, and then they've given us a 25 patch.
Just cut them in half. Just cut them in half, because then you're going to get better endometrial protection. From a short-term point of view, it's fine. It may well be that
cut the Everall in half.
Yeah, cut the Everall Conti in half.
Right.
Because that's the one with the progesterone in.
Yeah.
Okay. And there's absolutely, there's no harm in doing that, because the gel goes, the sticky is through the patch. So if you cut that in half, you're getting half of whatever's in it. It's not like 1/2 progesterone, 1/2 estrogen. It's mixed in together. Okay. So that's just some different oral preparations and patches. Again, I'm not a fan of the Fem7 Conti. You change it once a week. That's why it's called Fem7, but they don't stick very well. So why would you? But don't tell the Fem7 people that I said that, because I might get wrong. And again, the sequential combined, you've got your oral. So you've got some of the 3 monthly break ones for the sequential combined. I must admit, I've never used those before. I personally prefer to use a separate progesterone and estrogen, because I think it's much easier to manage in the long term. But I will start them on a combined patch, for quickness. If it just purs on anything, it's an easy way to go through. So that's just some more combined HRTs. So back to Catherine's vagina. So vaginal estrogen, it's a game changer for so many women. If you've been for a smear test and it's been painful when you've had your smear test when you're getting a bit older, ask for some vaginal estrogen before you go. If you're getting recurrent cystitis, recurrent urine infections, phone your doctors or your nurse practitioner and ask for some vaginal estrogen. If you're having painful sex, ask for some vaginal estrogen. If you're kind of put your clothes on, kind of sit down, or you can't walk because your vulva's sore, ask for some vaginal estrogen. If you've got a fanny, ask for some vaginal estrogen. Bottom line. I think is when you get to 45, and I know some ladies need, yeah, absolutely.
43 at least.
Well, 45 for the majority, but you can still have it before that. But 45, you get a card from the doctor's surgery saying, this is your menopause symptoms, tick these, here's your free vaginal estrogen, pop in and see us if you need any more help. So that's what we should be doing. We don't. So there's different types of vaginal estrogen. So here's Catherine's pessary.
I haven't used it.
So this is the applicator. That's not the pessary. That doesn't all go inside and stay inside. This is a plastic applicator. And you can see, we'll pass these around so you can all have a look and see. There's a little white tablet in there. Okay, so you just stick that in your fan, push the plunger, it leaves the tablet in, and then the plastic goes in the recycling or the bin to clog up the oceans. Sorry. So this is Vagifem. Okay, now that comes with a separate applicator for each one. So do you want to pass that around? Have a little look at that.
And you can use that every night for 2 weeks, and then a maintenance dose twice a week for forever. For some.
Forever, for most. So that's that. What we've got next, Vagirux. So Vagirux is pretty much the same, but you only get one applicator and like tablets in a strip that you just change it. As with that one, I think that one's much easier to use with a pill already in. If you get the Vagirux, just stick it on your finger and stick it in. Much easier than trying to get it in in that little hole. You'll be chasing it around your bathroom floor all night, especially if you haven't got your glasses on. God knows what you're going to end up with. So, there are some... Grown boobs. So the creams, we are having difficulty with the cream, getting the creams as well at the minute. So, but I'll show you. Now I haven't used it. I use this for me ladies with ring pessaries. So the applicator is unused. Okay, so this hasn't been near any woman's body. But again, the same thing. Screw that onto there. Fill it up with the cream. Stick it in your vagina and deposit it in there. Or you can just squirt it on your fingers and give it a good rub around. There's nothing wrong with being on a pessary and that if you need it, because you can use this just outside or you can put it inside as well. Okay, so that's that. And then there's a gel called Bliss L, which is pretty much the same thing, but it's just a gel. Okay, so a different formulation. I haven't had any feedback on that because we don't use it very often. So if anybody does get Bliss L, tell us if you make what it feels like, because I like to pass information on to ladies when I... Oh, I forgot to... Do you want to hand them round as well? I'll tell you what, we'll go this way with these ones. Have a little play, see what you think. Okay, doke. So like Catherine says, the standard dose... Everybody's talking about fannies now. Where's the toilet? So like Catherine says, the standard dose, the standard regime for that is 1 every night for 2 weeks and then 1 twice a week. But you can have more than that if you need more than that. It's very low dose, it's very low risk, and even most ladies with breast cancer can have this, but I would also recommend you discuss that with your oncologist as well. Okay, next slide please.
Nearly done, ladies.
Nearly done. Okay, so now this is something that I've really just started using, and this is mainly for older ladies who maybe can't manage the nightly estrogens. So it's called E-string, and it's a ring. Okay, and it's quite flexible, and you just stick it in your vagina and it stays there for 3 months. It's no good if you're sexually active, because it might come out. If you know what I mean. Okay, but that's really useful for ladies who maybe can't manage with it's like an Aunt Summer's party, isn't it, really, when you think about it? Aunt Summer's with a purpose. Now there is a non-estrogen vaginal preparation called Intra Rosa, okay, which is really useful as well. Again, it's not something that we use very often, because most of the time, women are fine with the estrogen preparations, but this one's great for women who maybe had breast cancer, who are nervous about estrogens. This is a really good option for them. Okay, next slide. Have I been talking for like 3 years?
Just thought, sorry.
So, testosterone. Now, we've already talked a bit about testosterone. Testosterone, like Catherine says, is produced in the ovaries. So, okay, we'll start losing testosterone from the age of about 30. All right? And then when everything else goes, we just feel the effects of the reduced testosterone more than we did before. It's only recommended in the UK for the loss of libido. Okay, loss of sex drive. It's not recommended for brain fog, energy levels, or anything like that by the British Menopause Society, the Faculty of Sexual and Reproductive Health, or the International Menopause Society. Okay, because there's not enough evidence to say that it will help. We know it's anecdotal. People say, yes, I felt better when I was on that, but there's no real evidence, randomized controls trials, so we can't recommend it for that. But we know that it does work, and Davina talked at length about that in our last, I know I'm talking about Davina a lot, mentioned it at length on our last program, but we can only use it for libido. So if you are speaking to your doctor and you want some testosterone, you ask for it, you tell them you've got a low libido. Okay? Otherwise, or they say, I'll have to refer you to a menopause specialist. I am a menopause specialist. I don't know what I have to do. So even I'm having the same struggle as you ladies. So, if you do feel like you could benefit from testosterone, it's for libido. It's important to be fully estrogenized first, so you do need to get your HRT right first, because if you take the testosterone when you're not estrogenized, it ain't going to do nothing, because you're going to be dry. Okay. We've already talked about the amber drug, already talked about that. Next slide. We are really, really nearly finished. So the review should be done at 3 and 6 months. If you're not feeling the benefit, and your partner will probably be able to tell you that, then you just stop it because there's no point. We do bloods before you start it. We do testosterone levels, serum, sex hormone binding globulin, which will calculate your free androgen index. You don't need to remember any of that. I can't even remember any of that, so don't worry about that. And we will check your estrogen levels at that time to make sure that you have got enough estrogen. It doesn't matter what those levels are. We can still start you on it. It's for monitoring. So at 3 months, we should be checking those again to see if it's increasing and to make sure you're still within female normal ranges. And then we'll check again at 6 months and then annually after that. If you are finding the benefit, then we can keep you on it. Oh, it's a gel. It's a gel. Now, next slide, please. Currently, there are no testosterone products licensed for women in the UK. There is one over in Europe called Androfem, and you can get it on private prescription here, but you can't get it on the NHS. So we have to use man products. Okay. So maybe you can have the next slide, because I think there's pictures on there. So again, they're quite light pictures. So the gel, the Tostran gel, you would use 1 pump of that on your forearm every other day. Okay. The reason we tell you to put it here is because it can stimulate hair growth. So if you put it here, you might get a nice hairy patch on the back of your arm. So we haven't got any hair follicles on the inside of the arms here. So you, well, you can. I don't think you need it. Yeah, all about, yes, all about 80s eyebrows, all about 90s eyebrows. We're getting a good idea. Hey, we're coming up with all kinds here, aren't we? So yes, we haven't got hair follicles on the inside of our arms. So put it there, different place every day. Okay, every other day, sorry, for the Tostran. The tester gel comes in a little sachet. We haven't got any like little sauce sachets, have we? No, I mean just like little, you know, you like your little packets of ketchup, bit like that, and then you've got to make that last 7 to 10 days. So literally, you've got to open the packet and squeeze a baked bean sized amount out, and use that every day. Exactly. So if you do manage to get started on testosterone, I would be going for the Tostran gel, because it's going to be much easier for you to manage. I think you find that men do want to use them. Yeah, yeah, they don't have to. It's just because we need a much lower dose than them, so that has to last us 7 to 10 days. So the top tip that I've heard for that one is when you open it up, fold it down and put a paper clip on it to stop it from drying up. That's the best. That's the best I can do for that. Sorry. Like your vagina. So this was just a little bit about supply issues. I've spoken about it a bit throughout the presentation. It's really difficult at the minute to manage this. I mean, I'm literally getting anything between 5 and 10 phone calls and tasks a day to ask, they can't get this, what can they have instead? So it's really increasing GP workloads. We've got access to at our surgery, we've got access to the Boots online, we've got access to the Boots system, so we can see what they can access, which is really useful, because then I can make sure I prescribe something that the woman can get, rather than having to go to the chemist and then coming back and then going back again. The government has said that the pharmacists can now, if you prescribe something and they can't get it, they can give you an alternative. That's in theory. In practice, pharmacists aren't confident or competent enough to be able to make those decisions, so they just bounce them back to the surgery. But the government has said under the serious shortage protocols, pharmacies can do that. So from your perspective, if you've been told, if you get a gel and you can't get the gel, then if you're on 1 pump of gel, you can, and there's a little table, you can say, well, can I have a 50 microgram patch instead, and see if they'll do that for you. Okay, so just again, gives you a bit of ownership, gives you a little bit of confidence in asking for what you feel like would benefit from you. Okay, so we get emails from the British Menopause Society when things change with a list of the different preparations to say this is available, this isn't. But honestly, we did get a supply of the estrogel a couple of weeks ago, gone off the shelves within minutes, like toilet roll and COVID. Okay, oh, ta-da! Any questions? I'm sorry, I think that went on a little bit longer than I anticipated it, so I hope it was okay for everybody. Yes.
Hi, can I just say I've been taking the using the gel, and obviously with Hampton, my brother, who's a 63-year-old man who's on holiday in Spain, has been running a pharmacy.
Oh, bless them.
And he's managed to get 3 months worth.
Wow.
And I'm not giving any more. So if any of you are going on holiday, make sure you know what you're asking for.
Yep.
Because in most European countries, well, in some European countries, you don't actually produce a prescription. So
Is that worth, are you on our Facebook?
Yeah.
Is that worth just popping just something on our Facebook?
what is name and his phone number?
Is he married, like, or what? What's he saying?
Don't want to go there.
I don't want a third divorce.
No, you're right.
Well, no, just so that ladies are aware of it.
Yeah, yeah.
You can check lots of other bits. I'm good for it. There's no problem with these gel at the moment.
Have they not?
No, I'm going to get my lips shot. Yeah.
You better get down there now because there's lots of ladies who's going to get the prescription. No, yeah, absolutely. But the Boots order, this is the system that Boots stores order from. So your Boots might just already have them on the shelf and not have very many ladies who are getting it. So it depends what the pharmacies have got sitting on the shelves. And some patches are running out of stock because everybody who was on gels is now getting the patches. So, but they can't. No, it's lots of different things. It's supply and demand. Just not the manufacturer's not making enough of it for the demand. You know, there's lots of different reasons. So.
And then you went and changed onto a patch.
You might, but it's about getting that level right. So if you're on 1 pump of gel, you want a 50 microgram patch. If you're on 2 pumps of gel, you probably need 75. And if you're on 3 to 4, you need 100.
When you're getting enough.
You feel better.
Well, because if you've had the symptoms for a very, very long time, then you go on the, let's say, the patch, and yes, you feel better, but you're like, am I as well as I could be, or is this all I can ever have?
Very individual. It's very individual. Everybody's got different levels of what's acceptable to them.
But what would be, how would you know if you were on too much, for instance?
You probably wouldn't. You probably wouldn't know if you were on too much.
Yeah.
Because you wouldn't all of a sudden start flying or, you know, feeling absolutely amazing. You would just, what we're aiming for is just to get you to the level where you feel okay. You feel like you can't overdose on it. Yeah, no. And we don't check estrogen levels. We very rarely check estrogen levels unless somebody's been on multiple different preparations and they're not feeling any benefit. Then we might check their estrogen levels to make sure they're absorbing it.
I'm on the committee one called Barnett, and I went and said to the doctor, the lady doctor, I don't think it's strong enough, and I don't know, because I was never assessed on it. I was just given this patch, and I then looked it up and saw that it was just like a middle patch.
Yeah.
And I was like, well, is there a stronger patch? And she said, no. And I said, well, I feel like I really had you lost.
So that's the case where you would cut them in half.
She gave me then a prescription for the estrogen only patch to put on alongside.
We don't really recommend that. Again, it's the progestogen.
I started bleeding.
Because you didn't have that extra progestogen.
Yeah.
So your best bet is to go back and ask for a separate progestogen, so estrogen, and
Could I not just do what you said, which is like,
Yeah.
the patch then? So I'm on like 1.5 patches.
Yeah, but you're going to run out quicker, so you have to discuss that with your doctor. Otherwise, when you go back in 2 months' time, because you've used your 3-month supply of patches up in 2 months, it doesn't equate. So you need to tell them that yes, what I've started doing, because I've been told from different forums that I can cut my patches in half and use 1.5 patches instead of 1 patch and an additional estrogen patch, because that's safer for me and it's worked better for me.
They didn't wait for my periods to stop.
No, I would do that, because I don't understand why anybody would want to have a period every month.
No,
but that's just me.
But then I still had every 28 days.
Yeah, because you can.
Even with
That's what I'm saying. Even on the combined, your periods might be the same. They might be erratic, but with a sequential, we know that you're going to get a bleed every month. With a combined, anything could happen.
Can I ask a couple of questions? Sorry, I don't want to take all of it. The first one's, I was ready to, well, I put a repeat prescription. I've been on the well context for 3 months. And I didn't think I'd be able to just put in a repeat prescription. I thought it wouldn't back. And I've been fine on it, but now I'm a bit worried that I'm not getting enough progestogen. Well, how would you know that?
Well,
they have just approved it, and I have got my delivery today, thankfully. My other question is, when I was expecting to have to go back to see the nurse, I was going to go in and say, this wasn't the one I actually thought I was asking for in the first place. I thought I was asking for the one that Dorena was telling everybody, the
Eutrogestin.
Yeah. Would there be any benefit in me going and saying, I want to come off that one?
Yes, absolutely. If that's what you want, if that's your preferred, then this is your treatment. Yes. You write an e-consult, and somebody put the link on, was it you that put the link on last week on how to do an e-consult, and just put an e-consult in, because that's the easiest way to get the information across, because then that gets stored in your records. So put on, I'm currently on the Everell Conti with an extra 25 microgram patch. Please can I go on to Eutrogestin every night and a 75 microgram patch? So tell them what you want, because that's what you're on at the minute effectively. You're on 75 micrograms of estrogen, so you want...
Mine said 50.
Yep, but then if they've given you an extra 25 patch, didn't you say they've given you an extra? No, that was you. Yeah. So if you feel like you need more,
I don't think I need. I feel all right.
But you prefer the other. So just say the Eutrogestin and a 50 microgram patch separately. Just say you prefer to have separate estrogen and progestogen. Please, can I have this?
But if you're on the combined patch, from what I've understood, just the one combined patch, it should be the right amount of
progestogen, But some ladies will
it's a combined patch.
But it's a different type of progestogens. You know, the lady might prefer the bioidentical progestogen of the Eutrogestin, because it's a synthetic progestogen in the patch, and I'm not quite sure which one's in the Everell Conti. I think it might be norethisterone.
You suggested, am I right in thinking it's made from yams and it's body identical?
Yes.
And is the other one bioidentical? Because I thought I'd asked for it.
These things mean not body identical, bioidentical. Forget about those things. Okie doke. Most progestogens are synthetic. Okay, so norethisterone in Everell Conti is a synthetic progestogen. I hate norethisterone with a passion, but that's just me. But Eutrogestin is body identical, so it's the same molecular structure as your own hormone, the same as the estrogens that we're using. Okay, all apart from Premarin, all HRT is plant-based. It's not. There's no animal in them. No gelatin, no nothing except for the Eutrogestin.
Synthetic.
Yeah.
See, I didn't think that.
Because norethisterone, it's a synthetic progestogen.
I feel like I want to rewind you now to where.
Well, you'll be able to have a look on the YouTube.
Also, because we're going to be doing a guest speaker one week and then a copy and chat the next, and a guest speaker and a copy and chat, because we're going to still do it weekly, but have that break each week. So, for example, if we didn't have a guest speaker next week, we can take it back, and then Kerry's going, because Kerry's going to do with us every week. So then it gives an opportunity.
Until I'm sick of years.
So then we've got Kerry to be able to can I just check with you, Kerry? Last week you said, can I check that? And then it gives an opportunity for yourselves to discuss with each other, what are you doing?
And to do your own research when you go home, have a look at it yourself on the British Menopause Society, etc.
So if you haven't had a period for quite a long time and you go on that, would your periods not come back?
They shouldn't come back in the first 3 to 6 months of starting HRT. You might get bleeding, but then it'll go away again.
You might.
You might.
In my experience was I haven't had a period for a year, and then when I started for 3 months ago, I did straight away within a week. Then I'm having again.
Yeah, and that's the thing. Like I said last week, hormones are witchcraft. It really is. Every woman is different. Every hormone is different. How you react to a hormone is different to how you will. And your body's changing as the years go on. So in 2 years' time, whatever hormone replacement therapy you're on might need to be changed. It's not an exact science. It's very much everybody's different. And the idea is just so that you've got an idea of what to expect, okay? And what to ask for and how to approach it yourselves moving forward. So there was you've turned it off. There was just the resources. It's all right.
But it will be going on.
Yeah.
It was
No, it's no, it's fine.
I will. When I say we, means our team. This all will go on tonight on the final part.
It's all right. You were hoping I was finished, Sylvia.
Fingers crossed it's going to go on the YouTube channel. I hope you all subscribe, because when you subscribe it means I can hopefully get it live streamed. This one hasn't been live streamed because we needed 50. We did get 50 subscribers at 10 o'clock last night, and apparently I had to have 24 hours after the 50. So this will go, hopefully this will go up as a recording. Hopefully next week will be live. We're doing the raffle. Any more questions?
I think everybody's just flushing.
I know it is.
I hope that was okay for everybody and aimed at the right level. Give me cream back.